All right, let's jump right in. We're talking about intravenous fluids. They're one of the most basic, life-saving treatments in any ICU. But here's the catch. It's not as simple as just hanging a bag of saline. In the high-stakes world of critical care, IV fluids are a classic double-edged sword.
And that really gets us to the heart of the matter today. Can you have too much of a good thing? I mean, when a patient is critically ill, these fluids can literally be the difference between life and death. But what happens when that exact same therapy starts causing a whole new set of problems? It's a tricky balance that ICU teams have to manage every single day.
Probably the best analogy for this is firefighting. Imagine a building is on fire. Your first priority, your only priority, is to put out those flames, right? So you douse it with water, that's your IV fluids, to save the building. But once the fire is out, you've got a brand new problem on your hands. All that water damage. This really is the perfect way to think about fluid therapy, because it breaks it down into two totally distinct phases.
So let's talk about phase 1, putting out the fire. In medicine, we call this the resuscitation phase. The patient's in shock, their blood pressure is tanking, and their organs aren't getting enough blood. The mission is crystal clear. Get fluids in and get them in fast to bring their circulation back and save their life.
Now, when it comes to sepsis, that's a huge body-wide infection that causes shock, the guidelines give us a really famous starting point: 30 milliliters of fluid for every kilogram of the patient's body weight. It's a number that's drilled into every critical care doctor. But, and this is a really big but, it is nowhere near the whole story. And here's why. The very same guidelines that give us that number immediately follow up with this crucial piece of advice. They say it's not a hard and fast rule. It's just a place to start. It demands constant, frequent reassessment, and it has to be tailored to how that specific patient is responding.
Okay, and this part I find absolutely fascinating. The experts who wrote the guidelines are completely transparent about this. They state, right there in the document, that the certainty of evidence for that 30 milliliters kilogram rule is very low. And that just perfectly shows you a fundamental truth about medicine, right? So many common practices are built on limited data, which is exactly why the judgment of the clinician at the bedside is so incredibly important.
So what if the fire isn't an infection? What if it's massive bleeding from a serious injury? Well, in that case, the whole strategy gets turned on its head. If you pump in too much fluid, you'll raise the blood pressure, and that sounds good, but it can actually blow apart the fragile blood clots that are trying to form, which just makes the bleeding worse. So this leads to a really counterintuitive strategy called permissive hypotension.
So for a trauma patient who's bleeding out, the guidelines recommend doing the exact opposite of what you do for sepsis. The suggestion is a restrictive fluid strategy. You're basically walking a tightrope. You give just enough fluid to keep the vital organs going, but you keep that blood pressure low enough so you don't mess with those life-saving clots before a surgeon can get in there and stop the bleeding for good.
Okay, so the fire's out. The patient's initial shock is under control. But that brings us to the second and equally critical part of this whole story: dealing with the aftermath. We're back to that water damage. This is the big challenge of fluid accumulation, where all those liters of fluid have left the patient, well, literally waterlogged.
And believe me, this is a very big deal. All that extra fluid, what we call fluid overload, is genuinely toxic. It can flood the lungs, making it harder for the patient to come off a breathing machine. It can overwhelm the kidneys and cause injury. It can even slow down wound healing and make the bowels stop working. So just let that sink in for a second. The very same fluid that just hours ago saved this patient's life now becomes the next major threat to their recovery. The solution has created a whole new problem, and the clinical team has to pivot to fight a completely new battle.
And that brings us to the final chapter of fluid management, the de-escalation phase. The goal does a complete 180. We're no longer putting fluid in, we're trying to actively get all that excess fluid out. And doctors have two main tools in their toolkit to make that happen.
First up, you've got diuretics. You probably know them as water pills. They basically signal the kidneys to work overtime and make more urine to get rid of all that extra fluid. But if the kidneys just aren't cooperating, the next step is ultrafiltration. That's a form of dialysis that acts like a special filter to mechanically pull water right out of the blood.
So how do these two compare? Well, diuretics are definitely the first choice. They're way less invasive, they're cheap, and they're available everywhere. The guidelines strongly suggest using them. Ultrafiltration, on the other hand, is a much bigger intervention. It's more invasive and needs all this specialized gear and staff. So while it can be a lifesaver, the guidelines actually recommend against using it routinely, saving it for cases where the diuretics just aren't getting the job done.
And here's some really powerful data that shows why this approach matters. One big analysis showed that using a clear diuretic strategy made a huge difference in how many patients ended up needing more invasive kidney support, like dialysis. The bottom line? For every 1,000 patients treated with the strategy, 34 of them were spared from needing to go on dialysis. That is a massive win for a simpler, less invasive approach.
So, after all this, what's the big takeaway? I think it's that when it comes to IV fluids in the ICU, there's just no simple recipe. This is not cookbook medicine. It's a delicate dance, a constant balancing act that really requires the clinician to understand the patient right in front of them. It is, truly, the art of critical care.
And honestly, this quote from the guidelines says it all. It confirms that the best medicine isn't about memorizing rules. It's about empowering skilled doctors and nurses to make smart, dynamic decisions based on the unique person they're treating, their specific condition, their history, and how they're responding in real time.
So let's just lock in these key points one last time. For initial sepsis, that 30 mL per kilogram is a very weak suggestion, not a command. For a bleeding trauma patient, think restrictive, less is more. For fluid overload, diuretics are your friend. Don't jump straight to more invasive options. And did you notice that theme running through all of this? The certainty of the evidence is often low, which puts the focus back on clinical skill.
Which kind of leaves us with this one big question to think about. As our understanding of critical illness gets better and better, it really seems like we're moving away from these one-size-fits-all protocols. So is the future of ICU care less about fixed rules and memorizing numbers, and more about a new era of truly personalized medicine, where even something as simple as a bag of IV fluid is tailored exactly to the individual? It's a really fascinating shift to watch.